Welcome to our Quality Assurance Review Conference. The QUARC Grand Rounds is an opportunity to review cases and topics that are related to quality and patient safety issues. Today we have the pleasure of hosting Drs. Colin and Iberti, Shirley Jane, and Charlie Schneider, who will be introduced by their faculty mentors. Dr. Beth Raucher, Vice Chair for Quality and Clinical Affairs, will moderate the session. Dr. Colin Iberti is a PGY2 resident in our internal medicine program. After completing his PGY3 year, Colin plans to practice internal medicine as a hospitalist. Dr. Shirley Jane is a PGY3 resident in our internal medicine program as well, and after finishing next month will stay on as hospitalist in the Division of Hospital Medicine. And Dr. Charlie Schneider will be staying at Mount Sinai as a fellow in the Division of Gastroenterology. Faculty mentors Dr. Harry Cho, Director of Quality and Patient Safety for the Division of Hospital Medicine, and Dr. Jonathan Arend, Assistant Medical Director for Clinical Operations and Clinical Quality for the IMA, will be introducing our speakers. Please join me in welcoming Drs. Raucher, Cho, Arend, Iberti, and Jiang. And Snyder.
Good morning, everyone. Hope you had a great holiday weekend. I'd like to thank the chiefs for helping to pull this conference together. With so many different moving parts, it's not so easy. So welcome to QUARC. I think we're going to have a contest to change this name, maybe going forward. Quality Assurance Review Committee. Quality assurance, that term is about a decade old, so I think we're going to move into the performance improvement era in the future. Today's objectives are to describe the ACGME mandate to train residents in quality and patient safety, review the goals and objectives of our own curriculum at Mount Sinai, explain the difference quality versus research, introduce the speakers and projects. The faculty mentors will be doing that, and at the end we'll take questions. Everybody will come up and you can ask them about their projects. In 2012, the ACGME pulled together a group that decided that there were other areas that were important for physicians coming out of training programs. And they approved 6 focus areas that training programs were required to make sure that residents were good in these areas, like professionalism. We had a duty to make sure that their duty hours and fatigue were at reasonable levels, so we all know about duty hours. We had to teach them mitigation, so I think they put in the naps and other things that residents could do to tell us when they were too tired. Transitions in care, otherwise known as handoffs. We had to ensure appropriate supervision for residents. And 2 of the very big areas were healthcare quality and patient safety. From 2012 until now, the ACGME, at these CLARE site visits, visited over 200 institutions to see how they were doing with these 6 new focus areas. And with regard to patient safety and with quality, they found that they were at various stages of implementation. Mount Sinai, we're doing pretty well. John Duval is the CEO of the ACGME, and he's also the CEO of the Virginia Medical College, I believe. And he said, imagine the systemic impact of having all our graduates across all disciplines and across the health professions emerge from their training programs as experienced in the tools and methods of quality improvement and the science of patient safety as they are in their clinical specialties. I think it's a very, very potent statement, and I think it reflects on what we're doing here at Mount Sinai. There are goals and objectives for the quality and safety curriculum. We prepare physicians to be stewards of safe, high-quality, high-value, patient-centered care. And I think some of you who know the Institute for Healthcare Improvement, Triple Aim, will recognize that these are the values of the Triple Aim. Teach key principles of quality improvement, patient safety, and systems innovation to all the residents and fellows, and this does also include fellows in our training programs. Develop a culture of safety and quality that trainees carry with them throughout their careers, and to cultivate future leaders in healthcare quality and systems innovation. And we do attempt to do that. Many of our graduates go on to do quality fellowships, they do a quality and healthcare leadership track here, and we're beginning to see residents really interested in this area. So Many of them do projects before they graduate. I think everybody has to do something, and some will do a quality project and some will do a research project. And there's always some question about what constitutes quality and what constitutes research. And we always get the question, do I have to go to the IRB with this? So research, we know, is a quest for new information. We do testing, we evaluate designs and protocols, and it's systematic. Quality, on the other hand, takes what we've learned from research and translates it into clinical practice to improve the quality of health care for individuals and populations. It's not adding new knowledge to our profession. It's taking what we already know and trying making patients better. Project doesn't need to be submitted to the IRB. And it doesn't need to be, the intent to publish doesn't obligate IRB review as long as it's not a research project. And so what we've done is we've adapted the work from Duke, Wisconsin, many other hospitals. I've done this in my past, where we use a quality versus research questionnaire. And if all the answers to the questions we apply can be yes, this is not new research. This is taking standard of care information and applying it to improve patient care. Patients directly benefit from the projects, and that we can support practice change. We can say yes to all of those things, then we consider this quality. So these projects that you're going to hear today, and many of the others that you actually saw out at the poster session on Thursday, came to the Department of Medicine Quality Committee, and we reviewed them as a committee and approved them as a quality project. Whenever there's any question whatsoever, though, we do send them back to the IRB, just because we don't want it, it could be a gray line, and we don't want to make any mistakes in that area. So one other interesting thing is when I asked the mentors and others, faculty who work with residents in their projects at the end of the year, for quality projects, there were over 24. We came up with a list of 24, many of which were out on the poster sessions last week. And they're all terrific projects that are either coming to completion this year or will be in the next year or two. So, I really do want to congratulate all the residents in the audience who have participated in that. So, without further ado, the mentors are going to introduce today's speakers, and then we'll bring them up at the end for questions. So, I think, Dr. Cho, you're going to start?
Okay. All right, the first up is going to be Colin Iberti. Colin actually was born at Mount Sinai Hospital. He received his Bachelor of Science at Biochemistry in UCLA. He then moved on to internal medicine residency program here at Icahn School of Medicine. And he's actually interested in hospital medicine. He's a PGY2, and his focus is going to be in quality improvement and waste reduction. He's going to present an interesting project to you, title which is, Does This Patient Still Need Labs? A multidisciplinary intervention to reduce routine labs in clinically stable patients.
All right. Oops. I don't want to give the results away. All right. So as Dr. Cho mentioned, this project revolves around reducing labs. We'll talk about why this is important, and very important just to mention, and won't get into exactly, but this intervention very multidisciplinary, uses social workers, uses nurses, everyone on the floor to really try to increase improve our care of patients. I don't have any financial disclosures at this point in my career. I wish I did. And so we'll talk about, I'm going to introduce the just quality improvement in general. I'm going to talk about a couple core quality improvement concepts so that we can understand this project. I'm going to talk a little bit about background of reducing labs, and then also talk about our intervention, the results we have so far, and the future applications of this project. So first of all, I think quality improvement is really the study of errors. We see errors every day in our clinical practice. We report some errors, we don't report others. We notice some errors, we don't notice others. In 1999, the Institute of Medicine released To Err is Human. That kind of brought to light how many errors we were making in our clinical practice, noticed or unnoticed. And more recently in the news, out of Johns Hopkins and BMJ, there's a study saying that medical errors are the third leading cause of death, over 250,000 a year. And as you can see from this, a study admittedly from 2000 and maybe representing a different group of docs, but we have some room to grow. Pilots, we think about in quality improvement, we think of them sometimes as the gold standard of being able to transcend hierarchy, report mistakes. And I'm hoping now that in 2016, if we repeated this study, it would be quite a bit different. But these errors are errors that you notice. What I'm talking about today is overuse, over-ordering of labs, something that I think frequently goes unnoticed, and especially as we get further and further away from the Epoch Order tab in our training, we notice less and less as well. To understand this study, we have a couple core quality improvement concepts that we need to go through. The first is PDSA cycles. That's plan, do, study, act. I think we're all familiar with the randomized, placebo-controlled study. This is a very different model. This is a model where you don't need a control group, you don't need a placebo, you don't need to wait 12 months to find out your test was negative. And I really like to think about in the sense where you have the master bench researcher that spends their whole life researching a myriad of questions, but really focused in one area. And I like to think that with the PDSA cycle, you can go through that not in a lifetime, not in a whole career, but in a couple years. And so the Plan, Do, Study, Act cycle is an iterative cycle. You build upon each cycle as you go through it. The first being a plan. You need to have an aim, you need to have a target. You need to plan an intervention, most likely in a small trial group, not in the whole hospital. And then you need to study. You need to run the test, see if it works, see what doesn't work. And really importantly, you need to not only see if you get the results you want, but see what was hard or difficult about this, what worked, what didn't, what can we improve for next time. And then finally, you act and you change your study for the following time. And if everything's going well, you're going uphill. As you change the cycle, as you're rolling, you're improving each time. And so instead of waiting 12 months to get the desired results, you're changing the process each month to get the results that you wanted. And then also, in 2001, another Institute of Medicine article, Crossing the Quality Chasm, they were discussing that in this age where we have so much more information, so many, Epic, all these EMRs, everything's coming in so fast, how are we going to still give the highest quality of care to all our patients, regardless of whether we're in New York City or elsewhere in the country? And so they came up with these 6 core principles: safe, timely, effective, efficient, equitable, and patient-centered. I'm going to be talking about efficiency. We're trying to avoid waste, including waste of equipment, supplies, ideas, and energy. In my particular case, waste of ordering too many labs. Charlie will be talking about timely. He's trying to get colonoscopies for people quicker than they were getting them before. And Shirley will be talking about safety. But I think it's important to know these 6 concepts and these 6 tenets because it really incorporates all of quality improvement, and there's so many different projects that fall under this umbrella. Then they're all patient-centered. Sure, we can make that a bracket, an umbrella over all of them. And then every quality improvement talk needs a burning platform, I should say, to jump off of. Hopefully not a bridge. You need to set a picture of why is this important? Why are we doing this? Why do we care? And the common one is economics. And if we show here, this dotted line at the bottom is extrapolated from 2011 estimated GDP of our national health care expenditure, and if it was just flat, it would continue, obviously. But it's probably not going to be flat, and this is our business as usual curve that goes up. And in 2012, talking about eliminating waste for U.S. healthcare, in 2012 in JAMA, these authors postulated that if we actually just eliminated waste, we could keep this curve flat. And so I will be talking about this large wedge of overtreatment, but there's also administrative complexity, which if we had the same administrative cost as doctors in Canada, we would save $27 billion a year. But there are all these other failures and waste that we could eliminate in our system. And so a little background on this project. We have a problem with labs, I would say. It's very easy to go into Epic and type that I want 7 weeks of labs for this patient. I want a CBC, a BMP, a MAG, FOS every day. And I think especially on the teaching service, we see that constantly. And so we postulated, Dr. Sega, Dr. Cho, and I, that we could do something about this, that there was benefit into doing this. And so we looked for other resources that might help us. And so this is probably one of the largest, more important studies in this field. In 2014, out of the Journal of Medical Quality out of UCSF. And they were pretty aggressive. They decided at UCSF to not let residents order repeated labs anymore. They would have to order labs every day if they wanted them the next day. They were going to teach residents why this was important 6 times over 3 years, so every 6 months. They were going to pay the residents $400 if they decreased their labs by 5% year over year. So each year, another 5% decrease, another $400. And they were going to give a scorecard to each resident and attending. And you know, this is a pretty wide-ranging bundle of interventions. It seems like it should work, and it did. Overall, they reduced the labs on teaching services by 8%. Even after paying all the residents $400, they saved $2 million in hospital cost. There were no changes in their balance measures, which are measures that you look at if you change something that might unexpectedly make care worse. And so there were no changes in readmission rates or mortality. But the interesting thing here is even though they continued the intervention over 3 years, no resident in the 3rd year got paid. After 2 years, they saw this reduction, but in the 3rd year, there was actually an increase in labs. So it's not necessarily sustainable despite all of these interventions. And so we looked at this study, we thought about our problem here, and we thought, and in quality improvement, you have to first diagnose a problem, and the way you do that is, we call a process map, but is a flow chart of the process that you're going through. And so we start in the upper left corner with a patient admitted who has daily labs ordered, and we start in the bottom right with a discharged patient. We don't need to go through all the steps, but the important steps that we found were that are the ones with these stop signs. These are areas where a doctor, an MD, NP, RN can intervene and see if we still need labs. And so when the nurse delivers the IDP, which is an individualized discharge plan, meaning that the patient should theoretically be ready to go in the next 24 to 48 hours, that's an area that should bring up questions. Does this patient need labs? When the provider returns to answer discharge-related questions, does the patient still need labs the next day? They could have a discussion with the patient. And then as the provider prepares for discharge, are they transitioning the medications to PO? Do they still need labs? And finally, they should be asking themselves this question every day, but unfortunately it doesn't happen. Are these labs truly necessary? And so our intervention, first our aim, was to reduce labs in this targeted population of people stable for discharge who have been IDP'd by 25%. We started in a small trial group, which was the ADS services, which are the non-teaching hospitalist-run services. The reason we did that is because they have this multidisciplinary rounds that are mobile that goes to bedside at each patient. on these 2 floors, and we thought that was a really good time to unroll this intervention. And so we wanted to start there. And then we incorporated this prompt in every day as they went through, as the social worker, the MD, the nurse, the physical therapist were at the bedside on these non-teaching services. They asked, can we IDP this patient? If so, can we discontinue labs? And hopefully, but since you're right in front of the patient, has this been discussed with the patient? And then going back to our PDSA cycles, the first time we did this, we tasked the medical director of the unit to be there to ask these questions. Well, obviously there are some problems with that. The medical director has other responsibilities, isn't always available. And so we noticed that we just weren't asking these questions often enough. And so our second PDSA cycle was actually twofold. We wanted to have someone else who could ask the questions. So we had social workers ask the questions, we had nurse managers ask the questions, and we also wanted observers to see if we were actually doing this every day. And so our results, 2 run charts, which is the average monthly frequency of labs and over time. And as you can see, there are 2 gradated marks here, the first PDSA cycle and the second PDSA cycle. After the second PDSA cycle, we went on what is called a run, where we had a trend downwards and then 5 points below the old median. And that suggests that there was a significant change. The change was from 50 to 41.7% with a significant p-value over the course of this time. But obviously we're not where we want to be at 25% below, which was our original aim. And then we also looked at it another way, which was average number of labs per patient per day. And this was also stratified by whether this was 72 hours from discharge, 48 hours, or 24 hours. And there's small trends downwards in all groups, but significant was the 72-hour patients. We went from 3.28 labs to 2.98 labs with a significant p-value. And then future applications, this is already being applied. So, one of my main jobs on this project was to try to figure out how are we expanding this to the teaching services after we did the ADS. And many of the residents, many of the attendings may have already seen this, but there's a patient safety checklist that was rolled out to the West teams first, then the East teams, and now I've seen it on the subspecialty teams as well. And it's not just related to labs, but it's making sure this question is asked on every patient every day. And so our key other quality projects that we've had great success with urinary catheters, central lines, and VTE prophylaxis, but also now we're trying to expand this to labs. And that's this project. I just want to say, I was born here, my dad was a doc here. It's such an honor to be able to present at Grand Rounds. I really, in front of all my mentors, the hospital department, I want to thank Dr. Sega, Dr. Cho, Dr. Jiang, the wonderful residents that I get to work with every day, and the great clinicians that we learn from. Thank you so much.
Thanks, Colin. So I have the pleasure of introducing Dr. Charlie Schneider. Dr. Schneider graduated AOA from the Icahn School of Medicine at Mount Sinai in 2013 as a member of the Gold Humanism Honor Society. As a medical student, he received the Mount Sinai School of Medicine Spirit Award and the Ellen Parker Memorial Award for Outstanding Community Service in Geriatrics. Charlie became particularly interested in quality improvement after completing a fourth-year medical school quality and patient safety elective that was developed by members of the hospital quality leadership, including Doctors Brian Radbill, Brian Markoff, and Britton Shaw. And as a resident, Dr. Snyder has been awarded 2 Department of Medicine Advancing Clinical Excellence in Medicine grants to improve the direct access colonoscopy program at Mount Sinai, for which I have served as one of the mentors.
Hello, everyone. Here to talk about my project entitled Implementing an Electronic Medical Record Tool to Improve Direct Access Colonoscopy Referrals. The goals of this project are, by the end of this Grand Round presentation, You all have traced the steps of a resident-initiated quality improvement project. You will know to appropriately order direct access screening colonoscopies in Epoch, and hopefully more medicine residents will want to start their own quality improvement projects after this. So scope of the problem, colorectal cancer is the second leading cause of cancer death in the United States when men and women are combined. It can be prevented by detection and removal of precancerous polyps, most commonly by colonoscopy. But the National Colorectal Cancer Roundtable has cited that 1/3 of adults, 23 million in the United States, are not tested as recommended. The NCCR has set a goal of 80% of the population screened by 2018. And they call for organizations to build models of care that deliver efficient, high-quality colorectal cancer screening. The scope of the problem at Mount Sinai. So in February 2013, when I first started looking at this project, Mount Sinai had a backlog of 800 patients who were ordered for direct access colonoscopies, but they were awaiting scheduling and clearance. The rate at IMA in 2014, before we rolled out our first intervention, was 67.7% screened, which is similar with national numbers. This project started, but as Dr. Aaron said, as a quality improvement elective. So in my 4th year of medical school, I did the quality improvement elective. Part of that elective was we mapped out the entire process of what happens when a patient sits in an exam room. It is decided that the patient needs a colonoscopy for screening, and it is traced all the way through to the patient actually getting a colonoscopy. When I became an intern in July 2013, we were having difficulty getting our patients colonoscopies in IMA. So I went back to the process map. And this is the process map that I had created during that quality improvement elective. It really starts with the patients in the office. Patients are ordered for colonoscopy, and it travels all the way through for clearance, scheduling, registration, and then endoscopy. So Mount Sinai uses a direct access colonoscopy referral system. This is a system in which primary care doctors order the colonoscopy, and then patients are first cleared and then scheduled for colonoscopies without requiring a GI office visit. At Mount Sinai, what we do is we have a nurse practitioner who reviews each referral for colonoscopy and decides whether it's appropriate, whether the interval is appropriate, whether the patient's actually age appropriate for screening, and whether the patient's medically cleared. Inappropriate referrals from primary care doctors can hinder the timely scheduling and can create problems in patient safety. Just to show of hands, before this, did anyone know that we use a direct access system? If you did know that we used a direct access system, do you mind raising your hand just so I get a rough estimate? Okay, good. That was kind of my sense when I first started exploring this with residents and other primary care doctors, was that we just didn't really know that this was how the system was working at Mount Sinai. And it's hard to do a process properly if you don't know how the process works. So again, I made this process map. It starts with the office. Primary care doctors, including residents, order a colonoscopy in the office. The order gets sent to the GI clearance nurse who reviews the orders here in the clearance step, and then if the orders are appropriate, they get scheduled. If the orders are not appropriate, it gets kicked back to the primary care doctor. So the aim of this project was I wanted to decrease the percentage of inappropriate direct access referrals for colonoscopy and IMA by 20% within a 1-year timeline. So as Colin went over PDSA cycles, the first part was to plan this project. So we really focused on temporally the initial steps in the process. So what happens when the IMA provider orders a colonoscopy, and how does it get to the GI clearance nurse? In order to figure this out, I shadowed the GI nurse practitioners, and I interviewed the former director of endoscopy, Michelle Kim, in the summer of 2014. And again, really focusing on temporally the initial step. When a provider orders a colonoscopy, where does it go? So it turns out that the endoscopy unit at Mount Sinai already had a guide that they were following to judge our colonoscopy orders. So as residents, as FPA primary care providers, as Jack Martin primary care providers order colonoscopies, their orders were being judged for appropriateness based on whether they were safe for anesthesia, whether there was a high bleeding risk, whether the patients were having major GI symptoms, and the GI department had already decided what criteria they wanted to accept for direct access screening, so screening that didn't have to go to the GI office but could just be scheduled directly. So I electronically shadowed the nurse practitioner for a few months, and I basically watched the charts as the nurse practitioner was clearing them, and I reviewed 68 of her charts as she was clearing them, and I found that about 28%, 19 out of the 68, were deemed inappropriate and potentially unsafe. So patients that were too high risk, patients that were inappropriate for age, or on high-risk anticoagulation. And I created a Pareto chart. So Pareto chart is a QI methodology to kind of map out the most common reasons for error in a system. So on the x-axis here, we see the categories. So the categories that I looked at were ASA physical status, iron deficiency anemia, age, anticoagulation. And on the y-axis, we see the number of inappropriate referrals based on that category. And then on the other y-axis, we have them all adding up to 100%. So as you move from category to category, it accounts for all of the errors in the system, ideally. And so I use this to really focus in on the most common problems in provider ordering, which was ASA physical status, iron deficiency anemia, and age and anticoagulation. Just another way to represent this, for people who aren't used to the Pareto charts, this is just a pie graph, which shows the most common reasons that providers were incorrectly ordering colonoscopies. So high ASA physical status, that's the Anesthesia Society risk score, iron deficiency anemia, incorrect age, and high-risk anticoagulation were the highest and most common errors. So we use lean principles to really focus in on the Pareto data in order to create our next intervention. So what we did is Dr. Aaron and I created a new Epic smart phrase to guide providers in ordering the appropriate direct access colonoscopies. So it was a simple smart phrase. Providers could just put it in at the end of their note if they're thinking about ordering colonoscopy, and it just guides them. This might seem really kind of like basic information and information that you would expect that everyone knows, but it's just systemizing. It was like systemizing good behavior in ordering these colonoscopies. So, for example, is the colonoscopy to evaluate GI symptoms? If yes, then stop and refer to gastroenterology. The GI department decided that they want to see these patients first in case they wanted to do an upper endoscopy or further initial testing before colonoscopy. Is it age appropriate? So if the age automatically populated, if the age is less than 50 or greater than 75, the GI department wanted to discuss with these patients and make sure it was appropriate before just automatically scheduling without seeing GI. And anticoagulation, is the patient on warfarin or a novel anticoagulant? If so, then please send them to GI. So this was a very simple smart phrase. The second page of the smart phrase just had some prep information and the ASA table for providers to look at when they're ordering the colonoscopy, and the best phone number for the patient, which is something we often have to input. So went through 3 PDSA cycles. The first PDSA cycle was just myself. I piloted this tool just for usability, and I made I probably did 3 or 4 PDSA cycles on my own, just changing the usability, making sure that the functionality worked within notes. And then with education, I educated 1/3 of the resident firms. So there's 3 firms in IMA, and Firm B was the first pilot firm. At weekly meetings, we went through just the direct access process and the smart phrase tool, how to use the smart phrase tool. And then finally, we spread the intervention to all 3 of the IMA firms. So from September 2014 to August 2015, piloted this project, and I had 44 residents use the tool and 5 attendings, and that was 116 uses. So over that 12-month pilot, in the intervention group, we saw that referrals that were inappropriate dropped to 1.7%, and in the control group over that time, which was 115 patients, 115 orders where providers did not use the tool, the inappropriate rate was 15.6%. So graphically, it's just 15.6% when providers didn't use the tool were inappropriate, and 1.7% when providers used this new smart phrase tool. Providers who used the tool also appropriately referred 19 patients for GI consultation. So I looked back at providers who were using the tool, and if they used the tool, filled out the prompt, they then often canceled the direct access referral and instead referred to gastroenterology, and 8 of them were just deemed completely inappropriate for colonoscopy, and the providers decided not to pursue colonoscopy at that time. So what we did was use those 3 PDSA cycles to create a new Epoch Order, which uses speed buttons, and it's a lot easier to use. Some of the initial feedback from PDSA Cycle 2 was that providers were having difficulty remembering to use the tool and input it into their note. So we created quick speed buttons that providers can just click off, and if you click any yeses in the first 4, then you get this error message that says consult to gastroenterology required, and you're not allowed to sign your order. This should be rolling out this summer. So in conclusion, this project identified the most common errors in direct access colonoscopy ordering and created a successful EMR tool. We decreased the inappropriate direct access referrals, which improves patient safety by avoiding unnecessary procedures and potentially unsafe procedures, and facilitated the need for specialty consultation. And we are now standardizing this into an Epoch Order to spread to even more primary care practices. Thank you to my entire QI team, particularly Dr. Jonathan Aaron, my mentor and clinical champion of this project, Bridget Shaw, who's the project sponsor and mentor, Michelle Kim and David Greenwald, who are the director of endoscopies that I worked with, and Jiang, who's taking over the project and who's designing the new Epoch Order. And thank you to the Department of Medicine for the Advancing Clinical Excellence in Medicine grant that many of us work under on our quality projects. Thank you. All right. Last but not least is Dr. Shirley Jane. She comes from California. She's a graduate of the University of California, San Francisco Medical School of Medicine. And she also did a master's in public health at UC Berkeley. And she's here as a 3rd-year resident at Mount Sinai. And in July, she'll be joining us as faculty in Divisional Hospital Medicine, but this is her last tryout. And also, this project that she's going to tell us about, she was awarded one of the ASIM grants, and it's called Using Activity Monitors to Increase Patient Ambulation in Hospital Setting.
So today I'll be talking about my quality improvement project, which is about increasing inpatient ambulation. So I think the first question to really ask is, why is ambulation important? And it's something that we often forget about when patients are initially admitted, because we're so focused on stabilizing them and treating their primary diagnosis that we forget that we're actually a lot of times causing them to be less mobile. For example, connecting them to IV poles when their IV infusion has already been done. This is really important because just a few days of bed rest significantly decreases muscle strength as well as aerobic capacity. The Choosing Wisely campaign is an initiative of the ABIM Foundation, and they've really caught on to this. They have chosen ambulating elderly patients as an area of much needed improvement in the inpatient setting. So looking at the literature, very few studies have actually quantified the activity level of hospitalized patients. Kaiser Permanente did a large study in their patient population, and they found that the median daily step count of their geriatric patients was 962 steps. The University of Texas also did a similar study in their teaching hospital, and they found that their median daily step count was 468 steps. This is a far cry from the recommended 7,000 to 10,000 daily steps recommended for to maintain cardiovascular and musculoskeletal fitness. Daily step count in the inpatient setting has not been shown to relate to admission diagnoses or illness severity, but has been shown to correlate with mortality post-discharge, as well as an increase in 30-day readmission rate. Johns Hopkins has recently done a very highly structured and robust quality improvement model, which was basically ambulating their patients 3 times a day. And in this study, not only did they have to mobilize their patients 3 times a day, but they had to document every time their patients were being mobilized. This was shown to significantly increase mobility as well as decrease length of stay, but as you can tell, it's probably very difficult to implement in a lot of hospital settings just given resource limitations. So the objectives for my project were to quantify step counts for our 10 West general medicine patients, as well as to use different interventions to increase ambulation, such as mobility hour, which I'll talk about later. And I chose to use the Fitbit because it's accessible, it's popular, and I have one. But so does our president, popular athletes such as Shaq ONeal. So I thought, why not our 10 West general medicine patients? My specific aim statement is to reduce the number of falls per month by 25% over the next 3 months on 10 West with the implementation of mobility hour. And besides looking at falls, I also wanted to look at 30-day readmission rates, length of stay, and where patients were being discharged. Are they being discharged home where they came from, or are they getting debilitated during the hospital stay so that they have to go somewhere like subacute rehab instead of home? We started data collecting in our baseline group in October 2015, and we included patients that were on 10 West and general medicine patients. They also scored between CI to CL on the AMPAC scale. The AMPAC scale is a short 6-question questionnaire, and after the raw score, you convert it to a CMS score. And this score helps the physical therapist determine how debilitated a patient is. So in our project, we chose patients between CI to CL, so they were 1 to 80% impaired. We excluded any patients that were bedbound, roombound, or had altered mental status. So this is the protocol for our study, and we wanted to keep it really simple because we had one physical therapist to work with. So if the physical therapist on 10 West only sees patients that have a physical therapy consult placed. If they were eligible for the study and they agreed to participate, she'd put on a Fitbit and then just see them per typical unit protocol, which was 1 to 2 times a week. Once they were discharged or after 3 days, she'd take off the Fitbit and then sync the Fitbit data to the Fitbit dashboard. So again, like I said, in October 2015, we started data collection, and at this time, we programmed the Fitbit so that patients could only see the time. They could not see their personal step count. This is what the Fitbit dashboard looks like. On the x-axis, you have time, and on the y-axis, you have number of steps. So you can see exactly when patients are ambulating and how many steps they're ambulating at that time. So in our baseline group, we had 25 patients. 24% were readmitted within 30 days. 92% were admitted from home, but only 76% discharged home. And our length of stay in this group was 11.5 days, and we did have 1 fall in this group. Looking at our median daily step counts, so in our least impaired group, they walked about 2,600 steps in a day. Our CJ group walked about 500 steps, and our CK group about 240 steps in a day. So what does 236 steps really mean? I wanted to compare this to something we can all relate to, which is how many steps it takes for us to walk 1 lap around 10 West. So I did this, and it took me 93 steps. For someone who's middle-aged, it takes 130 steps. And we tried this with an elderly patient, and it took them 255 steps. So if you think about that, some of our patients are ambulating less than 1 time around the unit in an entire day, and you can see how this can lead to impairment during the hospital stay. So how can we change this? So in February 2016, we implemented PDSA Cycle 1, and this is what we call mobility hour. Dr. Cho, the unit director, and our nurse manager would meet every morning, go through their list of patients, and think about who could be mobilized. At 3:30 p.m., the nurses and the PCAs would walk these patients. We did this for 2 months and then realized it wasn't sustainable because the nurses, it was very difficult for them to just drop what they were doing at 3:30 p.m. and walk the patients. And so now the nurses and the MAs have the entire shift to mobilize their patients, and then we check in with them at 3:30 to see what's going on. Our second PDSA cycle happened in April 2016, and this is when we programmed the Fitbit to not only show the time, but also the patient's step count. And we thought this would be fun and interactive for the patients, and we have gotten feedback from patients saying that some of them are self-motivated by it as well. So looking at our results after the implementation of our 2 PDSA cycles, our median daily step counts in the CI group was 1,600, our CJ group 900 compared to a pre-intervention of 500, and in our CK group 750 compared to our baseline of 230. So as you can see in our more debilitated groups, the CJ and CK group, they are walking around more after the implementation of the 2 PDSA cycles versus the baseline group. Another really interesting piece of data is our 10 West Falls data. So prior to the implementation of mobility hour, our number of falls per month was 4.31. After we implemented mobility hour in February 2016, the number of falls per month dropped to 1.0. This is really early data, but also it is very interesting. Looking at our other outcome measures, post-intervention, 86% of patients were discharged home compared to 76% in the baseline group, and our length of stay decreased by 1 day. We did have 2 falls in the intervention group compared to 1 at baseline. So our next step will be our PDSA Cycle 3, and this will occur in June 2016, where our physical therapist, Jessica, will be giving personalized patient step count goals to the patients that we place the Fitbits on. We also obtained Fitbits for all the medical assistants, so we're hoping we can have friendly competitions among them to see who ambulates the most with their patients at work. So in conclusion, ambulation in our hospitalized patients is a lot less than we would like, but we're hoping through these different interventions we can increase ambulation to ultimately decrease falls, readmission rates, and length of stay to improve the quality of care we deliver to our patients. I'd like to thank Dr. Cho, Dr. Markov, and Dr. Nguyen for their guidance on this project. Also, I'd like to give a shout out to Hirsch, one of the medicine interns who's helped me a lot. And most of all, Jessica Mathis, our lovely 10 West physical therapist. We could not do this project without her. She really is the workhorse behind this project. Lastly, I'd like to thank the Department of Internal Medicine for helping fund this project as well. Thanks.
Thank you. 3 terrific presentations. So we're open for questions.
One for Charlie. First of all, I thought that was great by all of you. You also did a great job just elucidating all the key principles of QI and process mapping and Pareto charts. So great job by all of you. Really excellent. So one question for you is, you showed that you were able to decrease the incidence of inappropriate colonoscopy referrals. Are you hoping that that leads to better access for people with appropriate referrals, and are you starting to see that downstream effect?
Exactly. I haven't looked at that yet, but that's what we're hoping by decreasing these inappropriates that take up a lot of the nurse practitioner's time in screening and making sure they're clear, that we will speed up that whole step in the process of actually getting patients through the clearance step. And ideally, if we can show that our next tool works well enough to decrease inappropriate referrals, we might be able to even one day cut out the whole step of the nurse practitioner doing the clearance and just go directly from ordering to scheduling. Yeah, but I haven't shown that yet.
Yes.
For Colin and the labs, my question is, were we able to determine which labs were being, perhaps, I don't know if it's the best term, but inappropriately used the most during that 72, 48, and 24-hour period?
Sure. So we were only looking at BMPs, CBCs, MAG, and FOS. And it seemed, unfortunately, as you know, the CBC seemed to be the one that lingered the longest, whether that was to look for clearance of infections, bleeding, anything like that. The BMPs, really what we saw with most misuse was MAG and FOS, which there's very little evidence that you need to track on a daily basis. And the CBC was the hardest to remove and really remained stable throughout the intervention.
A question for Dr. Jiang, and I wasn't sure if I misread one of your graphs, but it seemed that the least impaired group was walking less
Right.
before the intervention. Is that right?
And it's because the number of patients in each of those groups was 3 for the least impaired. We had more patients that were in the CJ and CK group. So we had 12 patients in the CJ and CK group in both the intervention and the pre-intervention groups. So the CI group, we actually had very few patients in that group. And so it's probably a sampling error.
It's a random difference.
Right.
Just out of curiosity, how many in the room are wearing a Fitbit right now? I think you all need one. Any other questions? Yes.
Yeah, this has to do with the mobility project that you did. Back in the 90s at a community hospital in Long Island, we started a acute care of the elderly unit. So this is a geriatric question. And we used it was a multimodality approach where our rounds consisted of getting the people out of bed. The issue was what was their mobility and how could we improve it. And we had what we called a special place on the ACE, which was a community dining room and exercise room and other room where people went to. So there was some incentive. So we actually made rounds, got people out of bed. They went to eat their meal together, and then the ones that were highly mobile. And then afterwards, they could come back and do exercise strength training. So sarcopenia was also an issue. So my thoughts are that this could be what you outlined could be a component of a multimodality program that not only improve mobility, step count, but also sarcopenia, balance, appetite, a bunch of other things.
I think that's a great idea. I think most of the studies I have looked at these major institutions have implemented a multimodality program to increase mobility, and that's what we're hoping to do long term as well.
Any other questions?
Just have one comment about the, just to clarify. So the 67.7% of IMA patients getting up to date on the colon cancer screening, probably more like 60% just based on the report. Some errors in the report in the last, as of the first quarter of this year, it went up to 75%. So there were a number of interventions that we've been doing to improve that performance, but Charlie's project is certainly one of them, so it's certainly going in the right direction.
Okay. Yes.
So in terms of the laboratory, the fixed costs are still fixed no matter what. Big savings come from needing fewer machines, fewer technicians. How much money is actually saved if you met your goal of going down by 25%? Because the cost per test, either added or subtracted, is very small.
Yeah, there are a couple things I would say to that. So one, labs, unfortunately, especially unnecessary labs, don't always come back how you want them. And so one way to reduce cost is not to get them and then not to have longer length of stay because you're chasing some lab result that ended up not being true. That's one part. The second part, you're absolutely correct, and it is a part that we're working on But actually finding out the direct cost to the hospital for each lab is like a labyrinth. You can't get a direct answer out. We've worked with multiple experts in the hospital. We've really tried, and I do think that's where the big costs are. You're correct, but it's something we're still working on getting a straight answer from the hospital about.
That's the dilemma of hospital administrators versus us doctors. Unless you can decrease an FTE or take down a machine, they don't think there's really a cost savings. But if you look at the implications of a test that has a false result and what we have to do to make sure the patient doesn't have whatever it is. When you look at hospital-acquired anemia, which is a real entity, I think this is still a very patient-centered approach, even if we don't save a whole lot of money for the hospital.
And one other thing I would mention is that also as we get reviewed for patient satisfaction, labs are generally high up there on the least enjoyable parts of their stay. They're getting woken up at 4 a.m., they're getting blood draws maybe multiple times a day. And so as we look to those metrics as well, there might be benefit to be gained there.
And also, if we do things at the end of the stay, and then we're not sure really what they mean, there's certainly an increased length of stay, and that could be measured. We could definitely measure that. So any other questions? All right, well, I'd like to thank our residents, our mentors, for a terrific presentation. Thank you very much.